Hi, everyone. Thank you for joining the webinar. We'll be giving our speakers a few minutes to sign on, and we will get started in about 5 minutes. Hi, all. Thanks again for joining. As people join, we will be giving our speakers a few minutes to sign on, and then we will get started. Thanks for your patience. Hi all, welcome to our webinar, Principles of Pediatric Anesthetics. This is the second session of our Gradient Critical Care and Anesthesia webinar of 2023. Thank you again for joining us. For those who are here for the first time or those who have attended other webinars in the past, thank you. Before we get started and before I turn it over to our moderator, Dr. Papicho, I just wanted to go over a few housekeeping items and give you a sense of what the day will look like today and then what you can expect afterwards. So if you have any questions during the webinar, please feel free to use the question and answer feature to ask us or use the chat feature as well. Our panelists will be answering questions throughout the webinar as well as at the end. So please feel free to ask along the way. This webinar will be recorded and you will receive a copy of the recording following the webinar. If you do not receive a copy for some reason, it will also be available on our website, gradienthealth.org, under our training page, as well as our Gradient Health System YouTube page. And then finally, if you have any feedback or have any questions or any ideas for topics that we can cover moving forward, please feel free to email customers@gradienthealth.org. I will now turn it over to our moderator, Dr. Papicho, to introduce our panelists and go over the roadmap for this upcoming webinar.
Thank you very much, Mariam. Good afternoon to our participants. Good afternoon to our colleague panelists and presenters. It's a pleasure for us to have you all on this webinar today afternoon. We value the time that you spend with us, and we are very grateful because you are always there when we send you an invitation. Today, our topics, as it was announced, we're talking about pediatric anesthesia. We all know that pediatric anesthesia is a specialty after you finish your anesthesia training. We thought of picking this for different reasons that were enumerated among our objectives. So our roadmap will be pediatric anatomy and physiology, pediatric induction of anesthesia, airway consideration, fluid management, pain management, and consideration. All these, per se, they are topics on their own, but today, our presenters will give us the principles that we can use during our practice of anesthesia. Next, please. So to have this webinar, we have 3 great clinicians who have accepted to be part of the team that is going to share with us their knowledge, their experience. We'll first start with Dr. Samuel Sibanda. So it's Dr. Samuel Sibanda. Dr. Samuel Sibanda is a physician anesthetist, pediatric anesthetist at the University Teaching Hospital in Lusaka, Zambia. He's going to share with us the first part of the presentation. After Dr. Samuel Sibanda, we'll have Dr. Victoria Tarimo. Dr. Victoria Tarimo is a physician anesthetist practicing at Muhaz in Tanzania. She's also going to share with us our great experience so that we get to hear how she practices pediatric anesthesia. To finish up the presentation, we'll have Dr. Christo Tara. Dr. Christo Tara, she's also a physician anesthetist practicing at KCMC in Tanzania. We have a big team from Tanzania available here this afternoon to share with us their practice of pediatric anesthesia. Now I'm going to invite Dr. Samuel Sibanda to take it up and share with us the practice of anesthesia, the principle of practice of in pediatric anesthesia.
Thank you, Dr. Papicho. Is everybody, am I audible enough to everyone?
Yes, you are.
Okay, all right. I think most of the information has been put by Dr. Papicho that this is a highly skilled field which requires knowledge and also requires a lot of resources in order for us to be able to manage our patients safely and improve their life, quality of life after they leave our theaters. So there are many challenges which are associated with the pediatric anesthesia, which both involve the anatomical and physiological differences between the children and the adults, but especially you can actually go deeper and separate the children into neonates, infants, toddlers, and all that. But I don't think that's the essence of this. We want us to be able to grasp the principles of the management of these patients. So because of the anatomical and physiological differences in this young population, there are so many adverse events that occur compared to those in adults. We may go to the next slide. So as we were just saying that there's really a vast differences in terms of anatomy and physiology between adults and children. And one of the major things which we need to do as anesthetists is be able to understand their implications in terms of management of the airway, in terms of maintenance of anesthesia, in terms of analgesics, as well as in terms of recovery. So every decision that you make is usually dependent on the age in this population. And maybe we may also just have a look at some of the anatomical differences which relate to the airway in this population between the young children or the children and the adults. Next slide, please. So when you look at this picture, I think that this picture tells us a very big story about the differences in terms of anatomy, in terms of physiology. Though physiology may not be able to pick it from the picture, but when you look at the pediatric airway, comparing it with the adult, the first thing which is labeled there is the tongue. So when you look at the children, they've got a big tongue compared to adults. That is the proportion of the tongue in the mouth. It doesn't mean that they've got a big tongue in comparison to themselves, no, because that tongue for them is actually useful for them to be able to suckle, to eat, to swallow. So for them, the appropriate size. But for us anesthetists, when you look at it in terms of accessing the airway through the mouth, the tongue becomes an impediment for us. One other major thing which happens is also the tongue. When you give your drugs, you relax the muscles of the tongue, the adductor muscles of the tongue or abductor muscles of the tongue, thereby causing it to fall backwards and occlude the airway. So that's one thing we have got to look into. The second thing, as we said, it's a long floppy epiglottis, but it's also not as well shaped as in adults. It's more sigma shaped. I don't know, we don't have the diagram here, but it's more sigma shaped, which means it's more rounded. And instead of it, because of lack of muscles, there's lack of not muscles but cartilage. Because of lack of cartilage, it's long and becomes a floppy. So when you put your laryngoscope in the vallecula, that's why you cannot lift it. So because it remains floppy and long, so it has the aperture for the vocal cords. So because of that, we now usually recommend the use of a straight blade. So instead of going into the vallecula, you actually lift the epiglottis to be able to access the airway. The other thing is they've got a shorter, flexible trachea. Usually the trachea in small babies, especially in neonates, is about 4 centimeters, and it doubles as we grow older. And because of that shorter airway, it's easier for us to be able to intubate into the right bronchus. But the anatomical differences in terms of orientation of the separation of the trachea is actually they're almost at the same angle. in children compared to adults. Where in adults, we know that the right bronchus is short, is wide, and is straight. But in the younger children, especially this young children population, you find that it's almost the same. On the right side and on the left side, the orientation is the same. It's not like in adult where the left bronchus is almost at an angle, is narrower and is longer. So in these children, remember, it's a very short trachea. So if you push your tube in without looking at the gradation or at the length at which you have gone in, you may actually go deeper. And that's when you may find that your saturation is not going higher. And it actually happened to us this morning, where we pushed in the tube without looking at the length of the tube. So also they've got this higher anterior larynx, and this actually makes it also difficult for us to be able to intubate easily using the curved blades. They've got a funnel-shaped larynx, and I think for those who have been reading, I think this has been a very long contested issue, whether it's a funnel-shaped or whether it's straight or whether the narrowest part of the airway in children is at the level of the cricoid ring. But there's a paper which was done in 2018, and this one was a systematic review which was done. I think we may be able to share it in the references when you go down to the end of this presentation, where they actually found out that the major thing which was done was most of the measurements were done when the patients were under anesthesia, but not in vitro, where now they can do the proper measurements. So when they did it in vitro or in cadaveric specimens, they found that actually it's not funnel shaped and it's narrow at the level of the epiglottis. What is the implication of this? So the implication is that at the level of the vocal cords, you might not have a problem with your tube. But when you push it down at the level of the cricoid, that's where actually the tube may be stuck and may not move forward. So that's why now we need to be able to look at the appropriate tube size for our particular patients. And when we get the appropriate tube size, of which the easiest formula which we can use for the tube size is we usually say 8 genies divided by 4. Then you add 4 to the result of that mathematical equation, or say 8 genies divided by 4, you get the answer, then you add 4 to that number. When you do that, you get an approximately correct value for the size tube which you need, and you must have half the size below the appropriate size and half the size above the appropriate size, so that you've got 3 tubes which you can use as alternatives based on the assessment of the airway. Then when you look, as we said, we spoke about the cricoid cartilage being the narrowest point. But what is the difference when you look now at the adult? The adult, they say that they've got a short, stiff epiglottis. That's why it's because of cartilage, you can easily go into the vallecula and be able to lift it because it has cartilage in it. It's not only tissue or muscle, which is a floppy. That's one. Then the second thing is it's cylindrical in shape, and the narrowest part is actually at the level of the vocal cords, whilst the narrowest part is for the children is at the level of the cricoid ring. So you may intubate very well children, but you may actually get a blockade below the level of the vocal cords. But in adults, most of the time, if there's a problem, you see it at the level of the vocal cords. Next slide, please. So this is some of the things I was saying, that the anterior, the larynx is high and anterior is funnel shaped, and it's narrow is in the subglottic area or the cricoid ring rather than the vocal cords as in adults. And the epiglottis, as we said, is long and narrow. So this is just a summary of what I was saying in that diagram. The babies are more prone to airway obstruction because of that epiglottis, which can easily occlude the airway. And because of the shortness of the trachea, you need really to measure or to be able to say exactly the length or the depth of your endotracheal tube. Next, please. So one of the major things which has been contested is whether we need to ventilate the neonates or to put them, ventilate them manually, or allow ventilate them on using a mechanical ventilator. That is, put them on one of the modes, whether we are using SIMV or VCV or PCV or any other mode which is available on the ventilator, where we are taking over the breathing of the patient. So one of the major things which you need to understand is that in young children, and I think this goes up to the age of about 6 months, I think I may need to be corrected there. The diaphragm is got very few of the type 1 fibers, which are oxidative and fatigue resistant. So they've got just about 10%. So it means that this patient, if you allow them to breathe spontaneously, in a very short period of time, you are going to actually have this patient going apneic. Why? Because they tire easily. So what implication does that have on our management? That means that as an anesthetist, when you are looking at very young kids, especially from neonates, and I think up to about age of 6 months, I stand to be corrected on that, on the limit of the fatigability of the diaphragm. We need to be the ones who are ventilating the patient, not the patient spontaneously ventilating. Means if most of us, I think, we are familiar with the TPs, we can actually get the TPs and start ventilating manually ourselves until the procedure is done. But if the procedure is long and your machine, and I know this is a big if, because most of our machines are not well calibrated for managing or ventilating very young children, 1, 2, 3 kgs. Why? Because we are saying that if we are getting the topmost value, if we are using 8 mils per kg, you get for 1 kg, that means the kid is getting just 8 mils per tidal volume. And we know that most machines start their tidal volumes at 20. So that actually may present a challenge to most of us. So the best way maybe is you can use pressure controlled ventilation, which does not guarantee volume for us, but at least we can calculate and titrate it so that we can get the required volume which we need. But one of the easiest things for us is that we have the TPs which is available, so we can actually use the TPs to ventilate our patients, especially the very young ones. And the other thing is that they've got also very small lungs and therefore very little oxygen reserve. And as anesthetists, we know that the functional residual capacity is the one which is used, especially in apneic breathing, before we intubate our patient, which allows us to be able to intubate our patient without the patient desaturating. But in this, imagine if a kid is 1 kilogram, 3 kilograms, that means that they've got what? Maybe we say 35 to 45 mils per kg, if I'm not mistaken. So if we take 40, we say that's about 100, maybe 120 mils. And the kid is using, we know that most of the neonates, their respiratory rate or their metabolic rate requires at least between 7 to 9 mils per kg, which is twice the amount which is required in adults. And because of that, they are going to run through the 120 mils in no time, which means your apnea time becomes very short. So this is a patient who you don't want to give to somebody who is learning to intubate a patient. But this is somebody who you need to do. If you are the one who is the most experienced there, you take the airway. And if there's somebody who is more experienced than you, let them take over the airway. That is not a negative view on your part, on your skill, on your knowledge, but it's the way to bring safety to this child who is on the table. And when you see this, most of our children actually, they are prone to apnea. Some of them, especially I think most of us, and I'm one of the culprits, we don't usually calculate the postnatal age. What does that mean? It means, or post-conceptual age. That means the age at which the child, though the child has been born, but at what age were they born? Maybe they were born at 30 weeks. And if they were born at 30 weeks, now they are 3 months old. That means they're about at 42 weeks. Is it 42 weeks? That means they are just 2 weeks from the normal age of birth, which is 40 weeks. So they're actually premature. And if you calculate those and find that most of the neonates or most of the children who are below 60 weeks postnatal age, including the conception, which means if they are born at 40 and they are below 60 weeks in terms of their age, that is below 4 months, they are actually very prone to apnea. And these are patients who you need to be able to monitor very well in the in the recovery area. And when you give, especially narcotics, they may worsen the situation. Not that you shouldn't give, but what I'm saying is be cautious when you give narcotics in these children, because when they go in the recovery area, you need to have somebody who will be watching them until they are fully aware. All right, next slide, please. So we spoke about the immaturity of the diaphragm, but there are so many other organs which are immature, especially the heart. The heart is immature in that most of the muscles are not really distendable. So they're indistensible, which means they cannot stretch enough. So because they cannot stretch enough, it means they've got a fixed stroke volume. So if you are going to stress these children, what will happen? The compensation most of the time is, instead of them increasing their contractility or increasing their volume of stroke volume, they actually just increase the heart rate. So the stroke volume remains the same, but the heart rate is the one which is helping us to maintain the blood pressure or the mean arterial pressure in these patients. Unfortunately, when they go bradycardic, it means that the rate, the heart rate is going down, and it is the major factor which is needed to increase or to maintain the mean arterial pressure. So we start CPR, most of these in these young infants at the age of about at the heart rate of about 60, but that should not be taken as a what can I say, overall statement or a universal statement. Why? Because some of the causes are reversible, and one of the major causes of bradycardia in children is actually hypoxia. So if you quickly open the airway by using the jaw thrust or any other maneuver you can, you put in your oropharyngeal airway, and then you properly give 100% to this patient, you'll find that most of them will actually come. But if you do not do those things, or you've forgotten all the safety valve here is number one, go for CPR when the heart rate go below 60. So this is actually in infants, from maybe neonates up to infants. Then when you get to, from there going upwards, you now start modifying your approach to the management of this. So most of the patients are also very sensitive to drugs, and they are also prone to bradycardia. The kidneys are immature and produce large amounts of dilute urine. So, and because of their one, the skin, they've got a very large surface area, which predisposes them to dehydration very, very fast. And one of the major areas which they lose actually fluid is when you expose them to temperatures in the operating room, which are usually below 24 degrees. And I think we all love it, like in the summer, when it's very, very hot, what do? We turn on the fan. We also turn on the this air conditioning system. Most of the time we turn it to maybe 16 or 18 or 20, but that has been found actually to increase the risk of hypothermia. And we know the implications of hypothermia in that they can cause coagulopathy, they can cause increased metabolism, they can cause poor monitoring of the parameters, which you cannot measure blood pressure or oxygen saturation in a patient who is shaking. And unfortunately for children, when you look at it, they actually do not shiver. They got non-shivering thermogenesis. So they will be silent, and yet they are actually hypothermic. So that means we need to actually put a temperature probe on them. Next slide, please. Okay, so I think in summary, what I can say is the anatomical differences and physiological differences in children and between children and adults should be known by each and every anesthetist and must be appreciated. And also their implications must be known such that we may be able to prevent the sequelae of these conditions if they happen in our environment. Thank you. I'm handing over to the next presenter.
Thank you very much, Dr. Samuel, for that nice presentation. That was a nice intro and reminding us about the anatomy and physiology in pediatric. With that basic being shared with us, now I'm going to call upon Dr. Victoria Tarimo from Muhammad to take it up and talk to us about induction and other following topics. Dr. Victoria, please, you're on the floor.
Thank you very much. Just to make a small correction, yes, I am Victoria, but I am an anesthesiology resident at Muhimbili University. Just a small correction. So let's dive into pediatric induction of anesthesia. We all know that induction of anesthesia is one of the most crucial moments for us. And a lot of complications usually occur during induction of anesthesia. And that is true for adults, but even more true to pediatric population. So here we'll discuss just the principles that will guide us to a safe induction of anesthesia in pediatrics. Next slide, please. So to start with, we'll start with pre-medication. Nowadays, pre-medication is not routinely done. It may be done to some cases, but it's very, very rarely indicated. The pre-medication that we say is rarely not indicated is when we want to use medications for sedation or preemptive analgesia. For some cases, atropine may be used to prevent bradycardia and hypotension if you think you're going to use inhalational agents. We'll see later that some of them are associated with bradycardia and hypotension, but as a general rule, they are not routinely given in most cases. For the part of pre-medication, it's usually aimed at preventing or treating anxiety in these patients. Now, we know that anxiety is very, very common among pediatric population, and there's a number of ways of managing anxiety, medication being one of them. But one thing that is not in this slide is the non-pharmacological management of anxiety in pediatrics. I'll share with you some, but feel free to share in the chat box the non-pharmacological methods that you use to treat anxiety in the pediatric patient in your settings. One of the strategies is distraction technique, where we would use toys or videos, or we would allow our patients to blow bubbles or balloons, whatever that is making them comfortable and anxiety-free, we can allow them to do. Another method would be to bring the child's familiar item with them. For instance, if a child has a toy giraffe that is making them comfortable or make them familiar, you can allow them to come with that toy in the operating room. Also, environmental modification, that is to say the whole operating room or the preoperative area can have colors or toys that the patient are allowed to play with. Also, parental presence during induction can help to reduce anxiety in the pediatric population, since a familiar face can make the child feel safer. Another method is the use of virtual reality. That is an upcoming technology that other places are using. I know I have seen pictures from Kijabe Hospital. They're now using virtual reality. Maybe later they might share with us the effect of virtual reality and how every one of us can use it. So Before going to pharmacological management, you can consider doing the non-pharmacological approaches of anxiety management for your patients. Next slide. Please remember to share in the chat box what you do or you think can be done in your setting. So for induction, we know there are several induction methods. We do have inhalational induction. We do have intravenous induction. We can also do balanced induction where we use both inhalational and intravenous agents, both at lower doses with the aim of achieving balanced anesthesia with less complications. But unfortunately, we do not have a single method for all the cases. It's not like all the pediatric patients who come here will do inhalation induction or do intravenous induction. There's a number of considerations that have to be put in the choice of induction method. For example, the medical condition that the patient has. A child that has a healthy respiratory system, does not have any lung issues, or does not have any cardiovascular problem, you may discuss using inhalation or induction. You can use either of the methods, and most of them can tolerate inhalation or induction. But when your patient, let's say, has airway reactive diseases, let's say asthma, you might want to secure an IV line before induction and do an intravenous induction, because we know some of the inhalational drugs like halothane have a higher risk of triggering bronchospasms. So again, it's not a one way for every patient. Another example is the surgical condition. So let's say the surgical condition or the urgency of the procedure. Let's say it's an emergent surgery. You might want to go with an intravenous induction, because with an inhalational induction, chances of aspirations are high with your unfasted patient, the emergency patient. So an intravenous induction becomes a better choice. So every time you are choosing a method for doing induction for your patients, you have to look at a number of factors: medical status, surgical condition, the gestational age, as it has been said earlier, recent fasting, to see which method will fit for your patient. And also the experience of the anesthetist as well can be used as a consideration. If you are not experienced with an inhalational method of induction, you might want to go with an intravenous method of induction. But one point of importance here is that if your patient is unstable, or they're preterm, or they have a full stomach, like in emergency cases, it is very important to establish an intravenous access before induction. Next slide, please. So we have seen a number of differences between adults and pediatrics. Now let's look particularly in neonates. Induction in neonates can be a bit difficult compared to older children. Now we are comparing them to their fellow pediatric patients. For them, pharmacokinetics of the drugs are different. One, if you look at the volume of distribution, in neonates, they have a very, very high volume of distribution. What does this mean? It means that if you are using water-soluble drugs like thiopental, midazolam, suxamethonium, you'll need a very larger dose. So it is not uncommon that you use, let's say, 3 milligrams per kg of succinylcholine in a neonate patient, while in an older child, you might just use 2 milligrams per kg, and in an adult, you use 1 milligram per kg. This is one of the reasons. Another thing is they have a decreased protein level. Now, this is a risk to them because some of the drugs that are highly protein bound, for instance, propofol, thiopental, bupivacaine, have an increased risk of toxicity, because for these drugs to be safe, they have to be bound to the proteins. Now, if they don't have enough proteins, most of the drug would be just a free drug in circulation. increasing the risk of toxicity to them. Another issue is that they have a low fat and body muscle mass. This again leads to a greater level of drugs that are redistributed into fat and muscles like thiopentone. So it is important to know this because in most cases, you'd have to use larger doses. And as much as they have all these differences, they are not prone to complications that are brought by these drugs. So we have to be aware that there's a number of complications that will be even more intense to them compared to adults. Next slide, please. Okay, so here we'll discuss intravenous agents as well as inhalational agents. We'll not discuss every drug, but at least we'll pick the drugs that are common in our settings. We'll start with anticholinergics. I think atropine is one of the most common drug in our settings. We use it to decrease secretions, but also we can use it as a treatment for bradycardia or even a pre-treatment when you're using drugs that you think will cause bradycardia. Let's say succinylcholine or inhalational agents. We usually have it in hand whenever we are using these drugs. So one thing of importance is that when your patient has a narrow angle glaucoma, be careful with atropine because it can exacerbate an angle closure glaucoma, which will lead to vision loss in your patient. So that's just one thing to note. Another group of drugs, benzodiazepines. I believe diazepam and midazolam are the most common that in our areas. Midazolam is the ideal drug that is usually used for sedation. For cases that require procedural sedation, you might go for midazolam or diazepam. One thing of importance here is that if you are going to use them together with opioids, remember that they may cause hypotension as well as they might exacerbate respiratory depression. So remember that all the time you want to use benzodiazepines in combination with opioids. Induction drugs, we have thiopentone. Remember we discussed a high volume of distribution in neonates. So with thiopentone, again, you might need a very large volume so as to attain effect. And this may cause hypotension. So be very careful if your patient is hypovolemic. And if they're hypovolemic, you can choose to go with another method that is safer for hypovolemic patients. And also avoid it in heart diseases because thiopentone has a direct myocardial depression. So avoid it as much as possible for patients who have heart diseases. Propofol is a drug, again, which is very common and is used for induction as well as sedation in many cases. It has a variability in elimination. Sometimes it can have a long elimination time, but as a general rule, it is a safer drug if you compare it with thiopentone because it has lesser myocardial depression, but also it's a good drug because it has less postoperative nausea and vomiting. And of importance, reduce the dose so as to ensure that your patient wakes up early and you can do extubation early. Ketamine, we use it for induction and sedation, and it is very, very useful in hemodynamically unstable patients because it has less compared to propofol and thiopentone, it has a very, very less myocardial depression. But the benefit of ketamine is that it can provide analgesia, but also it is used for patients who have airway reactive diseases. And so one thing to note with ketamine is that it is associated with oral secretions, copious oral secretions. So it is a common practice to see ketamine being used with atropine. Also, it is associated with emergence delirium. Again, a common practice seeing ketamine being used with diazepam. One thing of importance here is that ketamine, diazepam, and atropine is not anesthesia as a whole, because there are some places that use ketamine, diazepam, and atropine as anesthesia. It has to be noted that diazepam and atropine are given with ketamine to counteract the side effects that are caused by ketamine. Next slide, please. And just in the previous slide, one thing that I haven't mentioned is that ketamine may be preferable in many cases because it does not depress the respiratory system. So your patient may be able to maintain their airway while you're using ketamine, making it a safer drug in some situations. Now we go to opioids. Opioids are generally used to provide analgesia and sedation. But one point to note is that all opioids are associated with respiratory depression. So the levels of respiratory depression differ between morphine and fentanyl and remifentanil, but they are all associated with respiratory depression. Fentanyl may be common among us, and we know it is 100 times potent than morphine, so it can provide a very good analgesia. But one thing to note is that it can cause chest wall rigidity and glottic rigidity. So in pediatrics, even a small dose of fentanyl can cause these two things, and these can lead to desaturation because even the vocal cords may close following that rigidity. Morphine, the same, it is used for sedation and analgesia, but we should decrease the dose when you're using it in neonates. And we should remember that it may lead to prolonged ventilation, so those should be adjusted. Remifentanil is more potent than morphine. I think it's 200 more potent than morphine. We like it because it is ultra short acting, it provides better analgesia, and sometimes it may be used for maintenance in surgeries that you don't want to use volatile anesthetics or you don't want to use muscle relaxant. Remifentanil can be used in their place. And the good thing about remifentanil is that it has a very short onset and a very short duration of action. So the moment you switch off remifentanil, few minutes your patient will be out of sedation. Methadone may not be a drug that is commonly used, but it has been used in ICU when withdrawal from opioids is suspected. So used also to manage opioid tolerance. Next slide, please. Okay, neuromuscular blocking agents. We do love our neuromuscular blocking agents for a number of reasons, because if your patient is adequately paralyzed, has adequate paralysis, intubation is going to be easier. You can, ventilation also is going to be easier. You can control the ventilation. There will not be so much patient fighting with the ventilator. Abdominal muscles will be well relaxed, which this is good for the surgeon. It can ensure immobility, which even provides more safety to your patient. But a number of factors are influencing the choice of agent. So just like any other drug that we have discussed earlier, the same with neuromuscular blocking agents. The time of onset will influence your choice, duration of action, cardiovascular effect, as well as clearance and elimination. So for instance, with the time of onset, let's say you want to do a rapid sequence induction, you might want to use a drug that has a quicker onset, let's say succinylcholine, compared to other drugs that have a longer onset of time. Duration of action, maybe you have a longer procedure that takes 2-3 hours. You might want a drug with a longer duration of action, like pancuronium. But if your procedure will last, let's say 30 minutes or 40 minutes, you might want to go with an intermediate acting drugs like atracurium. Cardiovascular effects, we know these drugs are associated with a number of cardiovascular effects, like pancuronium can cause tachycardia, can cause hypertension, while atracurium can cause hypotension. So depending on what you want or you don't want your patient to have, these are the things that will guide you in the choice of the drug. Next slide, please. So, succinylcholine, commonly known as suxamethonium. This is the drug of choice for rapid sequence induction. I've said earlier it has a quicker onset, which makes it a better drug for rapid sequence induction. Also, it's a drug of choice if you suspect your patient has a difficult airway. This is because it has a shorter duration of action. And we know if your patient has a difficult airway, you have given your suxamethonium, you've tried and done all the appropriate things, and you haven't been able to secure the airway. After a few minutes, suxamethonium will wear out and the patient will go back to spontaneous ventilation. So it's a good drug for if you suspect difficult airway. Also, we use suxamethonium to treat laryngospasms. If other methods like applying CPAP with jaw thrust have failed, you might want to go to using suxamethonium. Now, let's remember that we said this is a water-soluble drug, and thus in neonate they have a high volume of distribution, which means that they will need a very high dose of succinylcholine. So it's common in pediatric patients to have very high doses of succinylcholine. But we know succinylcholine has a number of complications. One is bradycardia. So we give them very high doses of succinylcholine. Let's remember that they are prone to getting bradycardia or sinus arrest. So it's a common practice to always have atropine in hand when we're giving succinylcholine. But in situations where you want to give a second dose of succinylcholine, it is advised to give a pretreatment of atropine before giving the second dose. That is to prevent bradycardia that can be caused by the higher doses of succinylcholine. Next slide. Other neuromuscular blocking agents, rocuronium. Rocuronium also has a shorter onset, and so it can be used for rapid sequence induction, but then you'll get a quicker onset when you use a high dose of 1 to 2 milligrams per kg. If you go with its usual dose, you might not get a quicker onset. So if you want to use rocuronium for rapid sequence induction, it is better that you go to the higher doses. The advantage of rocuronium over succinylcholine is that it does not have the complications that come with succinylcholine, for instance, bradycardia. So you can go higher doses safely. Another neuromuscular blocker that is not mentioned here that is probably very common is atracurium. Atracurium is an intermediate neuromuscular blocker, which has an onset of about 3 minutes and is very useful for short and intermediate procedures. So you have a procedure of 30, 40, 50 minutes or even 1 hour, you can go with your atracurium. One thing to note is that it is associated with histamine release and it can cause hypotension or bronchospasms, even though the likelihood is very low, but it's something to note, to have in mind when you're using atracurium. Pancuronium. This is very useful in long procedures, but we should note that it is associated with tachycardia and hypertension, one of the cardiovascular effects that I said earlier. So depending on a kind, there are some kind of patients that we would opt for pancuronium because we want some tachycardia, but the importance here is to understand that pancuronium will be associated with tachycardia and hypertension. The next question would be to ask yourself, do I want tachycardia in this patient? If I don't want any tachycardia in this patient, then pancuronium might not be the drug of choice. If you want to have it, then it might be the drug of choice. It is important to avoid it in surgeries where we want to discharge the patient in the same day, because we said it has a very long duration of action. Becuronium also is considered a long-acting agent, particularly in patients less than 1 year. The reason we like it is because it has no effect on the cardiovascular system compared to pancuronium, compared to trachurium. So if your patient has cardiovascular diseases, you might choose to go with vecuronium. Next slide. Okay, that was for intravenous drugs. Next, volatile agents. We do have a number of volatile agents, but for the scope of this evening, we'll discuss halothane, sevoflurane, and isoflurane. Halothane is the drug that is used for both induction and maintenance. It is used for induction, particularly in pediatrics, because its smell has first been described as a sweet and fruity smell. So, and not irritant to the airway. So it can be easily used for induction in pediatric. Another thing to note with halothane that is more potent, if you compare the three inhalationals, halothane, iso, and sevoflurane, you'd find that halothane is more potent compared to the rest two inhalation agents. And what does this mean? It has even more cardiovascular and respiratory depression compared to the other two inhalationals. So it's something to keep in your mind when you're using halothane. It also has a weak muscle relaxant effect that will can facilitate intubation without the use of a muscle relaxant in a situation where you think you do not want to use a muscle relaxant. So we should remember that using high concentration of for prolonged periods might lead to myocardial depression and pump failure. As I said earlier, that it is a potent myocardial depressor. Another thing of importance is that we know halothane can sensitize the myocardium to adrenaline, which can lead to arrhythmias. So it is a common practice to switch off halothane when you are using halothane, let's say for induction. It's a common practice to switch it off and switch to intravenous agents when a surgeon is using adrenaline. This is because adrenaline together with halothane may precipitate arrhythmias. Next slide. Isoflurane. This is the main agent that is used for maintenance in prolonged cases. You might not see it being used for induction because it has a very pungent odor and it is very irritant. So it might trigger bronchospasms in a patient that if you want to use isoflurane as your induction agent of choice. So be careful not to use it for induction. Compared to halothane, it has less myocardial depression, but compared to sevoflurane, it might have higher myocardial depression. But generally, it is safer to use in terms of the cardiovascular effects. Sevoflurane is commonly used for induction. It can also be used for maintenance. The reason it is safe to use for induction, first, it has a very rapid induction, but it has a pleasant and a slightly sweet and fruit smell, and it is not irritant. So it is safe for pediatrics as well. It has very, very few hemodynamic changes compared to isoflurane and halothane, which make it even a better profile drug for induction as well as for maintenance. Next slide. Okay, so that was a summary of intravenous and inhalational drugs. Now we go to airway management. Next slide, please. So to deliver safe pediatric anesthesia, there must be an appropriate airway management plan. Now, let's not forget what the first presenter shared with us concerning different anatomical as well as physiological changes in pediatric and adult patients. So considering all those differences, pediatric airway has always been considered as a difficult airway. So choice of your airway management will depend on factors, but always back in your mind you have to remember the the anatomical changes and put them in the back of your mind. So what are the factors that you need to consider when you're choosing the type of airway? And here we are thinking of either securing the airway with an endotracheal tube, or securing the air with an LMA, or using a mask as your way of airway management. Now, choosing these methods will depend on a number of factors. One of them, let's say, position during the surgery. If your patient is lying supine, it's a very short procedure. Let's say anal dilatation, that is 5-10 minutes. You might want to go with the face mask. And if considering your patient does not have any other problem, you might go with the face mask. But if your patient is going to be put in a prone position or in a lateral decubitus position, you may require a very secured airway. In this case, we are talking of an endotracheal intubation, an endotracheal tube that is properly secured. Let's say your patient is unfasted. In this case, you might want to move your attention to completely securing your airway with a cuffed endotracheal tube. You will not, even if the procedure is very short, you will not think of using an LMA, especially the classic LMAs that we use that cannot protect the airway. So you might go to the direction of using a cuffed endotracheal tube. The type of surgery also can influence your choice of airway management. Let's say a procedure is done on the airway. Maybe they're doing adenotonsillitis. In this kind of a case, you will have to secure your airway properly, cuffed endotracheal tube. While in other cases, if let's say that the surgery is on the lower limb, it is going to take, let's say, 30 or 40 minutes, you might want to go with an LMA. So the choice is not one way, just as we discussed in the induction. It's not one way. You see your patient, you discuss a number of things with the surgeon, and probably other anesthesia care providers on a better way to manage their airway. Next slide. So as I've said, when you're doing airway management, always remember the differences. Always anticipate that you might face some difficulties. So we go back to here, we go back to making sure that you have, as much as you have prepared your plan, you have plan A as well as plan B, as well as plan C and plan D in case anything fails. Adequate preparation prior to induction, prior to airway management, because as we have said, these are the difficult airway patients, so always be prepared. As I've said, mask airway can be used for short procedures, but again, remember there may be a risk of abdominal distension if the technique that is used is not good. If your procedure is going to be very long, controlled mechanical ventilation may be preferred than spontaneous ventilation, as we said earlier, so it might require intubation. Next slide. I think that's the last slide. Oh, no, it's not. So during intubation, one thing that probably have not been mentioned in the differences between the adult and the pediatric is that with the newborn, usually they have a large occiput. So if you put them in a supine position, the neck is already flexed. So this has two things. One, they are prone to airway obstruction because of the flexion of the head. But if you try to intubate, it will be very difficult for you to visualize the vocal cord if you put them in a supine position. Now, we know in adults, to achieve the sniffing position, we usually put a pillow below the head. Now, you cannot put a pillow below the head of a newborn because you'll make the neck even more flexed. So usually what we do, instead of putting a pillow, we just put a shoulder roll just below their shoulders. This will make them to have a neutral position. So this way, you'll be able to visualize your vocal cords. So that is one thing that we should note when intubating the newborns. As they grow older, the head tends to become normal, of normal shape. So you'll see how to go around positioning your patient during intubation. In case you face a difficult airway access, an LMA can be used for ventilation. We've always used an LMA as a rescue device. So it can be used for ventilation in case you face a difficult airway access. Next slide. Oh, thank you. That marks the end of my part.
Thank you very much, Dr. Victoria, for the nice talk. We really enjoy your presentation. Now we're going to invite Dr. Cristo, who's coming on board to talk to us about fluid management, pain management, and a few recommendations that she's going to make to us. Dr. Cristo, you are welcome and can take up the floor.
Thank you very much. I'd just like to thank my fellow presenters, Dr. Samuel and Dr. Victoria, for taking us through the presentation this far. And I will be taking you through this part of the fluid management, and a little later on, we'll go into pain management. So why are we so concerned about fluid management? Actually, we find that fluid management affects our outcomes. And if you actually get your fluid management right when you have a pediatric patient, it can greatly influence a positive income, as well as reducing the mortality of patients. And the vice versa goes, if you get your fluid management wrong, or if you don't pay particular attention to it, you could end up with an error that would lead to complications as well as negative outcomes for your patient. So that's why we want to take this time to really dwell on the importance of fluid management and how to go about it when you're with your pediatric patient. Next slide, please. Right, so when we look at our patient, we know that about 60% of their total body weight is made up of water. And if we take this 60%, 1/3 is allocated. Sorry, 1/3 is allocated to the extracellular fluid and 2/3 to the intracellular fluid. And of that extracellular fluid, we actually is made up of the interstitial fluid, as well as plasma and the transcellular fluid. So why are we so interested in this composition? We have to know that when our patient starts to lose fluid in whichever way, or lose any blood volume, most of it is going to come from our extracellular fluid. And keep in mind that that is only 20%. So we don't have much room in pediatric patients to lose blood or to lose much of our fluid volume. And how would you try to estimate the total volume that your patient would have, total blood volume? If you look to the right, you could see we have some recommended values for your patients. If your patient is preterm, they estimate that they'll have about 100 mils per kg of blood. If they're term, that's 90. If they're an infant, that's 80. School age, 75. And as we know, adults, we estimate that they have about 70 mils per kg of blood volume. So this is important for you to be able to calculate your patient's total blood volume, and there go on to make calculations for how much blood your patient can actually lose to still maintain a good hemodynamic stability. Next slide, please. So for you to be able to have an excellent fluid plan intra-op, you need to be able to assess your patient before you go into theater or before any procedure. You need to be able to tell, is my patient dehydrated? Are they well hydrated? And that will help you tailor your fluid plan towards the state of your patient. And I'm sure we're all aware of the signs to physically assess our patients in pediatrics. A physical examination where you look at their eyes, they could show that they have sunken eyes. A dehydrated patient would have a reduced level of consciousness. They might be lethargic. They won't want to make much movements. They might be disinterested when you try to talk to them. Their mouth will be dry. They'll have a dry mucous membrane. They might be crying, but they don't have a production of tears. Also, they'll have a reduced capillary refill time, and they'll be, when you look at their vitals, they could be tachycardic, and they could also present with hypotension. And urine is also a great indicator for you. The color, is the urine concentrated? The volume, how much is this patient producing, and is it adequate urine according to the weight of the patient and according to the time? So those are all important factors for you to be able to assess the hydration status of your patient. And as well, so you could put them in categories: are they mildly dehydrated, moderately dehydrated, or severely? And you could also help to categorize them. And I always urge the people that I teach or colleagues to always refer back to charts. You know, tables like this, they will always help us. Yes, you could try to memorize and remember, but once you refer back to a table and once you're able to place your patient in a category, it will be very, very beneficial for you to go from this step to then plan the fluid management of your patient. Next slide, please. So how do you choose the right fluid when you're going into the operation and for a procedure? Which way should you go? Are you aiming to give your patient blood? Are you aiming to give crystalloids, colloids? And what is the recent recommendation? So in a paper that was published by Robert Sampleman, in his paper, he had the following findings, or summary, should I say, that actually physiologically composed, balanced, isotonically electrolyte solutions are beneficial for maintaining hemostasis, especially in pediatric patients. That is leaning towards more of solutions like a ringer lactate. When we say a balanced solution, we mean, like, for example, the ringer lactate is a crystalloid that contains sodium, potassium, and chloride content that is closer towards the extracellular fluid contents. And when given, they actually help to maintain the hemostasis of your patient as compared to what we commonly know as normal saline or 0.9% sodium chloride. So we find that fluids that are more physiologically composed towards the balance of the natural fluids that we find in the body actually provide better results for us in terms of fluid replacement. And actually about optimizing the fasting times for our patients. When we give fluids up to an hour before surgery, they are known to better comfort the patient and help us to hemodynamically stabilize the patient. Next slide, please. So how do I calculate my fluid for my patient? Where do I start? We need to start by calculating the total volume that you're giving to your patient. And as you can see here, it's indicated to start with a maintenance fluid, which is quite a simple formula that we use daily in our practice in 4-to-1, which simply means for the first 10 kgs of your patient's body weight, you would multiply that by 4. If they still have kgs that are remaining, the next 10 kgs, you'd multiply that by 2. And if they still have whatever is remaining of their weight, you'd multiply that by 1. Then you sum it all up, and that will give you how much fluid you're supposed to give to your patient per hour. To get the daily requirement, you would just multiply by 24, and that would give you the total in a day. So by using that simple formula, you would be able to provide the basic maintenance fluid for your patient to keep their metabolic processes going. After you do that, you have to account for pre-existing deficits. What do I mean by that? How is your patient losing fluids? In which ways are they losing fluid? Are they excessively sweating? Are they vomiting? Do they have excessive urine output? Do they have diarrhea? Are they bleeding? You have to account for that as well. When you're done with that, intra-op, what are some of the ways they are going to be able to lose their fluid or lose their blood volume? Are they going to bleed from the operation itself? Are you going to lose fluid from third space loss, or are they going to sweat a lot? So these are all things you have to take into account. And I know sometimes we get so caught up in just giving the maintenance fluid of the patient, and we forget to account for the deficits of the patient and for potential losses that occur. But these are actually quite important as well. And to remember to give our fluid hourly, to give it hourly. Next slide, please. So in terms of the blood products, if you want to transfuse your patient, how do you go about it? We know we have whole blood, we have packed red cells, we even have fresh frozen plasma available in most of our centers, but which is the best option for your patient? So when we're talking about transfusing to replace, or if you choose the option of giving packed red blood cells to your patient, first of all, you have to calculate what we call the maximum allowable blood loss of your patient. So before you go into the theater, you have to have this. I always encourage students to have it all on a piece of paper or in your notebook, to paste it somewhere, so that you, throughout the procedure, you're looking back at your notes, you're looking back at your calculations, and you're following them step by step. And even if someone was to take over your patient, or you were to hand over the patient to someone else, they would be able to follow step by step the way in which to transfuse your patient, or to carry on with your fluid management. So in the case of calculating this maximum allowable blood loss, you'd first have to look at what is the estimated blood loss for this procedure. What is the blood loss going to be for this procedure? And then you'd have to multiply that by the patient's initial hematocrit from their full blood picture or full blood count that you did before the procedure. And then from that, subtract your lowest acceptable hematocrit. Of course, this would be subjective to different physicians and different anesthetists that are going in, but the decision will be up to you and your team. And from there, you'll be able to calculate it, how much blood loss you'd actually be willing to have. And once you get that, you can replace 10 or 20% of your estimated blood volume with the red packed cells. And usually, I know at my center, if we're giving packed red blood cells, we usually give it at 10 mils per kg. That's the dose, that's what we give initially. And if we're giving whole blood, we also give it at 20. We choose to give it at 20 mils per kg. So if you're choosing to transfuse platelets, I know sometimes we have very sick patients, even some patients coming in from the oncology ward, they might have features of thrombocytopenia or dysfunctional platelets. You might have to actually think about transfusing platelets for your patient. That could also be an option for you. And then in terms of fresh flows and plasma, FFP, usually we find our patients who have who are in warfarin therapy or associated liver disease or some sort of coagulopathy. We have to replace fresh flows and plasma. And we also give that at 10 to 15 mils per kg. So your goal would be at least to give 30% of the normal coagulation factor concentration. So these are the various options you have, along with your fluids, which we've already discussed. You could also consider these blood products. Next slide, please. So for fasting guideline, I know we have this notion that if somebody eats, they have to fast for 6 to 8 hours before they go into theater, or if we're pre-visiting our patients, we just tell them you should fast from midnight. But actually, we do have set guidelines and set standards that we ought to follow, because you find when you have longer fasting times, they actually decrease the prognosis of your patient and lead to several other complications. So when we have a guide, I know sometimes each center has a personalized fasting guide, or you can follow the American Association of Anesthesiologists guide. But it's good to have a personalized guide, especially for pediatric patients. So usually we say for clear fluids, when we say clear fluids, we mean if you hold up the glass, you have to be able to see through that fluid. So that is water, that is a plain black tea, that is juice like apple juice, something you can see through. If your patient has taken that, you have to give them about 2 hours before you can anesthetize them. If they've taken breast milk, that's their mother's milk, you have to give them about 4 hours before you can go in with them. Formula milk, that is also about 4 hours. If they've and also in terms of non-human milk, for example, cow milk, you give them about 6 hours. And if they've taken a light meal, I'm talking about maybe some sort of a soup, a vegetable soup, something light like that. Maybe they had a snack or like a fruit, that could be considered a light meal. You give them about 6 hours. And if they had something heavy, something meaty with starch, something like rice, you have to give them about 8 hours. Why are we so concerned about the fasting? Because of the bigger risk of aspiration. The last thing you want is to go in with your laryngoscope and the patient to vomit. So these are the guidelines that we can follow. And also the benefits of clear fluids up to 2 hours pre-op. Your patient has less thirst and hunger. You know, when children become hungry and thirsty, they become fussy, irritable, and they become even more difficult and challenging for the physician to be able to control them. And also the lower risk of aspiration. So I urge all of our centers to try to look again at our fasting guideline and see if the times are really appropriate, especially in terms of pediatric patients, not to just have a set time for all patients across the board, but to actually consider their meals and to consider their age as well. Next slide, please. So that sums up our fluid management, and we now go into pain management. And I think one of the major challenges that I think I have had myself as a young doctor is that we struggle so much to manage pain in pediatric patients because we actually are not so comfortable to assess it. You are dealing with a very irritable patient, a patient who most probably cannot articulate their feelings, cannot say where the pain is coming from, cannot help describe it, where it's radiating to, how long it's lasting, how it started, what aggravates it, all these things that would help us to assess the pain, they cannot give it to us. So we get up frustrated, and most of the time we end up leaving them. But I think as we go through the lecture, we'll be better equipped with tools as to how to assess our patients and provide the best pain management for them. Next slide, please. So the myths, there are so many myths about managing pain in children. And the first one is that we think children, they're too immature and they can't really conduct pain impulses, but that's wrong. They do conduct pain impulses and they do feel pain. And that infants don't remember because of cortical immaturity. We've had patients come in now, they are older, they come in and they tell us, oh, I had a previous history of a surgery when I was 5 years old, I had a tonsillectomy and I still remember the pain. So children, you do remember, and some people grow up with that trauma of the pain they had, and that children do not report pain when playing or sleeping, so they must get over it quickly. or they're maybe not experiencing. But you just must remember the golden rule that what is painful to an adult would most probably be painful to an infant and a child unless proven otherwise. Next slide, please. So what do we need when we're managing our patient's pain? We have to consider that the management of acute pain in neonates and as well as pediatric patients should be the priority for all practitioners for these patients. We should use age-appropriate pain assessment tools and understand the mechanism of action of that patient's pain. And we should also understand the roles in therapy of various non-opioid and opioid therapies to be able to treat our patients. Next slide, please. So going back to the assessment of pain, now we have various tools that have been developed for us to be able to assess pain, especially in pediatric patients. The first, obviously, is talking to the patient, trying by all means to ask them, where does it hurt? Can you say how much it hurts? When did it start? What makes it feel better? What makes it feel worse? Do you feel better when you lie down, when you sit up? Those kind of things. Also, we could ask them to give a numerical scale. On a scale of 1 to 10, how much pain are you feeling? Could you say how much pain you're feeling on a scale of 1 to 10? Then from there, you move to faces. What are the expressions of the patient? What are the patient's expressions, facial expressions? Are they showing that they're cringing in pain? Are they absolutely gut-wrenched in pain? Or are they calm? Are they able to tolerate the pain as well? Those are all expressions you can use. And then also using this FLAC, which is also a form of a behavioral scale that we use for our non-vocal patients, which is especially helpful in the post-operative phase of pain management, where you assess their face. So it's like a mnemonic. The F stands for face, the L for the legs, the A for activity, the C for their crying, and another C for consolability. How can we console? How consolable are they? That will also help you to grade the patient's pain. And of course, if you cannot, sometimes we get very sick patients. They're intubated, probably they have to be sedated, they're placed on vent, they're in the ICU. There's no way of communicating with them. You could assess their vitals as well. We know the signs of when someone is in pain, they have an increased respiratory rate, an increased heart rate, their blood pressure might be high, and also you could probably see a decreased urine output. And what are their pupils like? Are they dilated? And also, what is their basal metabolic rate? Is it increased? So there really is no excuse for failing to assess your patient for pain, because we have a variety of methods that we can use, both verbal, physical, and non-verbal. Next slide, please. So in terms of managing, I love this tool, the WHO World Health Organization Pain Step Ladder, which gives you a step-by-step way to manage your patient's pain, starting from the bottom. If your patient has mild pain, try to go with the non-opioid analgesia. So for example, we have our acetaminophen, also known as paracetamol, and we could also give non-steroid anti-inflammatory drugs. The most common, I'm sure we all use, we all probably carry in our bags, ibuprofen. Also another example is diclofenac. And you could also add your adjuvants to that, some anticonvulsants or antidepressants, or some drugs to relieve the patient's anxiety. If this doesn't work, you can step it up for patients that have moderate pain. This is when you take what you had, your paracetamol, your NSAID, and you consider adding a weaker opioid or perhaps a strong opioid to it. You can consider codeine or morphine. I know in our center, pethidine is an option for us, in addition to your non-opioid analgesia and to your adjuvants. If that doesn't still work for your patient, they're probably in severe pain, you take this whole step and you elevate it by giving higher doses of a stronger opioid, for example, morphine or fentanyl. And try to increase the time interval you give. If probably you were giving it 8 hourly, 6 hourly, you could probably consider giving it 4 hourly. So as you can see, the way the step goes is from the first way you planned out your pain management. It's like you take this complete bag and you move it to the second step where you add your opioid. If that doesn't work, you take this complete bag with your opioid and you move it to the third step where you try to increase your opioid doses or even go to a stronger opioid. Thank you. Next slide. So we know the side effects that come with opioid use. We have things like constipation, respiratory depression. Your patient could also become nauseous. They could even present with vomiting. And the ones in a pediatric patient. So before we even think of going to opioids, we should exhaust all our non-opioid forms of analgesia. And these could be in the form of paracetamol, which we've already said, your NSAIDs, which we've discussed, ibuprofen, diclofenac, which can be given orally. They could be given even in the IM form, and parenteral. I've come across some people that said, oh, we couldn't give this patient analgesia because they didn't have IV access, when actually we do have medicine that can be given parenterally. So there really is no excuse for allowing your patient to remain in pain when you have a variety of options to be given in different ways. IM is also another one, a good way to give. Intramuscular injection is a good way to give your patient analgesia, especially if you don't have IV access at that moment. Next slide, please. So the use of opioids, we have a variety of opioids that we could use. Some are long acting, some are short acting, but I would just like to emphasize for you the keeping in mind, bear in your mind whenever you administer your opioid to your patient, you should bear in mind the side effects that come with it. So for the constipation, you should already be ready to combat that with a probably increasing fluids for your patient, or prescribing a stool loosener like lactulose. You should be prepared to taper down your doses as soon as you achieve a good effective pain relief dose to avoid any addiction or tolerance. And you should probably prescribe an antiemetic together with your opioid to help your patient with the nausea they might be feeling as well. We have morphine. I know for pediatric patients, we can use a dose of between 0.05 milligram to a higher dose of 0.1 milligram per kg. Fentanyl is also a good one as it's super fast acting as well. We usually give it between 1 microgram to 2 microgram per kg. And depending on your patient's condition, you could opt for lower doses as well. But yes, this could be used in conjunction with your paracetamol and your NSAIDs as well. Next slide, please. So when we consider opioid-sparing interventions, a study that was done by Anthony and his team in managing the procedural pain in neonates using non-opioid sparing approach actually showed that a multimodal, or what we can call a multifactorial approach towards pain management actually provided the best or most effective ways of pain management in neonates and pediatric patients. So when we choose to combine a number of ways to provide analgesia for our patient towards different mechanisms of action, that is when we truly get the best results. And also the advantages of using a multifactorial pain management approach is that you get to use smaller doses of each drug that you're given. And that in turn reduces the side effects that you would have for each drug as well. So the non-opioid pharmacological options that you would have would be using a local or regional anesthesia, even non-pharmacological alternatives, encouraging skin-to-skin contact of the patient with their caregiver. It could be the mom or the father or someone they have a close relationship with. You could give sucrose. I know this is actually common when post-operatively to calm the patient down, just maybe 1 ml of sucrose just for the patient to suck on, and also breastfeeding the patient, and nutritive sucking when you provide the patient with a dummy to suck on. These are all interventions that have been seen to work to manage pain in neonates and pediatric patients. Next slide, please. So a neuraxial block, the options that we have are caudal block, or also known as an epidural or spinal anesthesia. With the caudal block, I would say it's a fairly simple procedure that could be done even by a junior doctor, anesthetist, or nurse, that provides a great pain relief, especially from the umbilicus going down. So for procedures that are done from the level of the umbilicus going all the way down. For example, if your patient is going to get a circumcision, or for example, they had a scrotal hernia repair, this would be a great way to give them effective analgesia either before the procedure starts. So after you intubate your patient, they're all set, the airway is secured, you could then proceed to position your patient. It's a sterile procedure that could be done with a fairly, you don't need any complicated materials to do it. You just need your local anesthetic, preferably a bupivacaine plain. You could use a cannula. Usually we use a 24 or a 22 gauge cannula. Wear your sterile gloves. It's a fairly easy procedure. So you could do it before the procedure, or you could do it after the surgery is done to provide that post-operative analgesia. And we found that it can actually help our patients from about 4 to 6 hours. It can provide a good form of analgesia for our patients. Next slide, please. So we could also opt for pediatric regional blocks. Of course, bearing in mind that there are doses that are related to the weight. So anytime you choose to administer any local anesthetic in terms of giving a block or infiltrating, be mindful of the maximum allowable dose for that drug, whether you're using lignocaine or bupivacaine. You should be mindful of the maximum allowable dose. You should also be mindful if you're mixing it with your adrenaline or if you're giving it as a plain local anesthetic. Next slide, please. Next slide, please. So whenever we're giving our local anesthetic, we should be worried about toxicity. We should be worried about local anesthetic systemic toxicity, which manifests in several ways. In the terms of your central nervous system, your patient could start having a reduced level of consciousness. They could now have seizures, or they could complain of dizziness. They would tell you that they hear a ringing sound in their ear, tinnitus, or they taste a metallic taste in their mouth. These are all signs that your patient has gone into a toxic state because of the local anesthetic you have administered. In terms of their cardiovascular system, you should always have a monitor set up to your patient before you administer, and you will see a bradycardia, you will see a drop in blood pressure when you get that local anesthetic toxicity. So these are very important for you to watch out for, which is why I emphasize again on the maximum doses, which you should already have in your mind before preparing your drugs for your patient. Next slide, please. So in conclusion, and to give further recommendations, anesthesia for the pediatric population is unique. Actually, no children are different ages, different sizes, different ethnicity, as well as different social background. And this presents a challenge and makes them such a risky branch of anesthesia and demands for precise and high safety standards. Adequate knowledge on the precise conduct of anesthesia is essential, and in order to avoid adverse outcomes and to actually achieve better outcomes. Adequate preoperative preparation is the hallmark of safe pediatric anesthesia. Don't ever let anyone rush you when you're preparing for a pediatric patient. Various options for pediatric induction of anesthesia exists. So you should always select what is most appropriate for you and your setting, what is safe for the patient, and what is available. Ensure you know the age, the weight, the surgical indication in order to administer precise and safe anesthesia to the child, which is why we always emphasize for you to see the patient before you even receive them to anesthetize them. And summon help where possible in all cases of pediatric anesthesia administration. Asking for help doesn't mean you're weak. Asking for help doesn't mean you don't know. Asking for help means you want the best possible outcome for your patient. I think that's all in conclusion. Thank you very much for the opportunity.
Thank you very much. We really appreciate your presentation, Dr. Creso. That was very clear. And those are the references that we use for us to make this presentation. That was used by our colleagues to make this presentation. We have 1 or 2 questions in the Q&A. Maybe I can ask one of the panelists to come across and answer the first question, or maybe to clear up the mind of Gift. Dr. Ndaba, can you clear up the first question asked by Gift Mukubesa?
Oh, thank you so much, Dr. Papicho, and thank you so much, the presenters. That was a very well presented discussion. So I think there's a comment in the chat box. Mukubesa is trying to seek clarification whether regarding fasting guidelines to fluids. I think that what we generally know up to this point is that the fasting guidelines, they follow the 246 as was explained during the course of the session. As for the 1 hour that our colleague is trying to seek clarification over, I think we might have to check literature, but I think from what is there now, we are still using the 246 rule regarding the fasting guidelines for children. I think our presenter took time to explain which foods or fluids that are supposed to be fasted according to the different timelines. I think for now, Dr. Papicho, that would be my comment regarding that question, unless there's any other additions. Thank you.
Okay, thank you very much. We have also another question.
If I may
Yes, please.
add, on the 1 hour, it is just that the 1 hour are a very, very new update. Very few societies have started using it. I think it's the European society that have started using the 1 hour, but most of us are still using the 2 hour guidelines.
Okay, thank you very much for that comment. I've seen Chab also is in support of 1 hour. It all depends on recent literature, as it has been said. So let's just be safe in what we are doing as a recommendation or prescription we're giving to our patient. And there's another question by Patrick. Dr. Sibanda, will you take it and make a few comments? Or Dr. Victoria?
I've seen the question, sorry, Dr. Victoria, but I'm not really understanding the question.
Me neither.
Mm.
But let me just say, when we say inhalation or intravenous anesthesia induction, these are just the methods which will enable you to achieve your induction to your patients. So you can either do intravenous, that is, you use your intravenous agents. You use propofol or you use ketamine with other IV drugs, or inhalational, where you put your patient to sleep by using inhalational drugs like halothane or sevoflurane. So these two are just methods to make sure that you achieve hypnosis and full induction of your patients. Choosing whether you're doing inhalation or intravenous, there are a number of things that we have already discussed. But I don't really know what Patrick meant when he said some of the signs of inhalation or anesthetic induction.
Okay, the next one is on how to use opioid in unit. I think here the presenter was clear and then emphasized to say be careful when using opioid because it causes respiratory depression. It's for prolonged use. Make sure that your patient is being ventilated so that they avoid going into hypoxia, knowing that hypoxia will lead to bradycardia and cardiac arrest. I think those are a few questions that were available in the question and answer. Before we close our day, I would like to acknowledge the presence of a few of our colleagues across the globe. I'll mention one or two. Dr. Kevin Omani, thank you, cardiac anesthesiologist in Kenya. Thank you for coming on board. Dr. Luimba Kaunda, thank you for participating. Great anesthetist in the eastern part of Zambia. There was also Dr. Dati Mohammed in Nigeria, who's also among us here as on the webinar. So before we close, maybe I can give 1 or 2 minutes to Dr. Dati Mohammed to share with us his great experience in practicing pediatric anesthesia.
Thank you very much, Dr. Pediatric. I'm sorry I joined midway. I was trying to join and then Magdalene had to help. But the slides I was able to follow, it's clear that justice has been done to this topic by the presenters. I truly enjoyed it. Let me share a few things that will improve the safety around the perioperative period when dealing with children. Over some years, I met an anesthetist from the US. And when he was amazed that you bring an adult and then the next thing is 8-year-old child, and then the next thing is a neonate. And so there were problems with logistics in terms of equipment. So he asked me, don't you have a PET box? I said, what is that? Then he explained. Then since that time, what I do, I try to get like operating rooms where it's not dedicated only to children or pediatric cases. Then it's good to have a PET box. The PET box will contain auxiliary equipment to the pediatrics, the laryngoscope, the TPs, and so on. So each time you are going to anesthetize a child, you bring the PET box nearby. You have most of what you need, rather than when after an adult and then you now have an infant, or you have an infant and then you are looking for one equipment or another. So that will improve safety. The other thing that we all need to be doing, if we are not doing, we should adopt that. If drug or not. You should calculate for each drug the fluid, what you need for that child. It's not when you need it, you start asking your colleague that, oh, can we dilute this, can we dilute that, and so on. Okay, so that has really helped. The other thing about fasting guidelines, you will discover that in different environments, you have different cultures, and then you get dislocated by logistics. When you plan your fasting guidelines, you've already given that guideline, and then you said fluid 2 hours before surgery or before induction, and then there is a problem. There is no electricity, and you are now told that it will take an hour or it will take 2 hours to fix it. How do you now readjust? So you need to factor that also. Children that you need to allow fluid to take, then you should readjust this fasting guideline as long as the time will accommodate that. So that you have to also consider. But the most important thing, and I do practice that, is that when I go to see these children, prescribing this fasting guideline, I call the mothers and I call the nurses on duty, and we agree, and I document it. And then when you say, okay, you should stop breastfeeding, or you should breastfeed at 3 a.m. So what I say is that, okay, you should start at 2:30. What I mean is that you should stop by 3 a.m. Not just to start at 3 a.m. and then the child is breastfeeding for an hour, and then your time is disrupted. Then the other thing I wanted to talk about was on pain, but happily I saw the presenter has dealt with that extensively and very clearly. Pain management, it is very important. For example, adenotonsillectomy, this one is from my family. My child had an adenotonsillectomy a couple of months back, and we had to give rectal diclofenac for him to be able to start feeding. And then the second day he's up. Otherwise, it's a problem. So you shouldn't be afraid to really treat the pain adequately. But if you're using opioid, the message is clear. You should be very careful. Respiratory depression. And so thank you very much for giving me the opportunity.
Okay, Dr. Mohammed, thank you very much for your contribution. Apparently, we have lost you. Maybe we'll take this as an opportunity to call upon Maggie, Magdalena, to come in and close up the webinar.
Thank you so much for our panelists. Thank you so much, Dr. Crystal, Dr. Sibanda, and Dr. Victoria. Thank you so much. That was an excellent presentation and study. Some of us have learned a lot. Much Dr. Papicho for heading all this. It was quite an informative presentation. What I would like to say is thank you so much also for our participants, because without them, we would not have had this webinar. I just want to request that if you could go to our website and see the anesthesia machines that we sell, and they all come with in-depth training. This is not the only one. This is just a follow-up. They come with in-depth training and support, both biomedical, both technical and clinical user. So thank you so much, and happy to see you in the next topics to come. Thank you.